Can you guys hear me? Yeah. Everyone can hear me clearly? All right, perfect. So I just want to thank everyone for coming to the first All New York City Emergency Medicine Conference. But I also want to say you're welcome, because I know this is probably the latest you guys have slept in on a conference day. Probably you can thank the OBGYN department, because they were supposed to have a conference here this morning, and I heard that it was canceled yesterday. Although you could have started at 7 a.m., which is what my plan was. So, anyway. I'm Kaushal Shah, I'm the Associate Residency Director here at Mount Sinai, and I'll be introducing all the speakers today. Wow. So sorry, yeah, I should mention this is a Prezi. I'm sure you guys have seen this before, or at least have heard of it. It makes people a little bit dizzy, so just hang in there if you focus and don't fall asleep. That's how you don't get dizzy. So, the main reason we wanted to bring all of you guys here together on a Wednesday conference day is that there's so much talent out there. New York City is probably the best city in the country, maybe in the world, and it attracts lots of great physicians, great residents, but we have so many programs that everyone's doing Wednesday conference at their own place. So we figured once a year, maybe even twice a year, depending on how this goes, we would get everyone together to do just focus on medical education. The problem with a lot of these other things is health policy and trauma. It's really focused groups. And here, what we really want to do is just have a kick-ass educational conference for you guys. Okay? So the first purpose is definitely to educate. Next, you guys, there's lots of EM residents out here in New York City. But you aren't familiar with them. If you start coming to these conferences, look around, see what these faces are. If you meet them in a bar, you should be able to go up to them and say, hey, I'm an emergency medicine as well. You buy the next round of beers. But I joke about that, but that's how you actually collaborate. That's how you make connections of what are you interested in, and that's how big things happen. So the other thing in terms of connecting is, I don't want you guys to think of your residency versus their residency. In New York, we really are one big program. So, there's going to be a guy named Dan Egan, who you may or may not be familiar with him. He does a lot of HIV stuff. So if you're interested in that, and there's no HIV person at your place, you should be able to call him up. I'll give you a cell phone number. Find me afterwards. He's a very approachable guy, as are all of our speakers today. So really, think of this as one big community of residents of emergency medicine, and you'll see them at the ASAP and SAM and all the major conferences. So definitely, we want to promote collaboration, so start talking to people next to you. And finally, I just want you guys to start thinking big. It's really important to help your departments, help out interview season, make your departments better, but start thinking broader. Think about New York ASAP, there's lots of committees you can join. There's SAM has interest groups and committees. EMRA has a bunch of things that you can join. So that's also going to help your department. As you start doing things in the bigger world, you'll see that you're going to just introduce more educational things, more administrative things to your department. So definitely start thinking big. So the theme today is emergency physician, the ultimate diagnostician. So that's what all the speakers are going to start focusing on. We have a fantastic list of speakers. There's about 9 residencies here and 9 lecturers, one from each residency. We're going to speak for about 20 to 25 minutes, hopefully. If everyone speaks quickly, we might even get a break sometime today. Okay, so I'm going to run through the different residencies that are here. And what I want people to do is, if you're part of that program, I want you guys to just clap or just shout out so we know. So Mount Sinai, you guys here? So I have to mention Elmer. This was actually a picture taken and published in the New York Times a few years ago. So this really happened. You can't make it up, but it really is. There's a T in this. So, I also want, Scott Weingart's going to speak a little bit later today, and I just want to give him a shout out because he's done a couple things. One, it was really his idea to put this whole thing together. I ran with it, but it was definitely his idea to make this all happen. The other thing is, I built a Google website for this New York City conference, and he said, let me build you a better one. So he built this whole, and it's a very nice website. It's going to be able to put all the video of all the lectures on there. We'll be able to use it year after year. So it's something that hopefully you guys will go to often. We'll also have all the events that are happening in New York City. So all the different conferences where you guys get together will be on there. So people look out for that. We're going to be doing that. Oh, the other thing I was going to mention, before I forget, you're going to get evaluations shortly. On there, all the speakers are there, and we're going to put a check mark next to the best speaker. The reason we're going to do that is a couple of things. We're going to put that person on the website and promote them. That's something they can put on their CV. And year after year, if we have a best speaker, we can make a whole list of all the great speakers in New York City. Okay, so fill out the evaluation forms. I want you guys to put anything that you want on there in terms of breakfast sucked, there was too many people, whatever you think is we can make things better. All right, so NYU Bellevue, you guys out there? The speaker from there is going to be Anand Swaminathan, and he's going to be our first speaker. That is real? Mike Heller's here to speak. Lincoln Hospital. I thought you guys were much bigger residents. And Elaine Joseph, I know we're starting later than you guys. Elaine Joseph is going to speak for Lincoln. Eric Worley's going to speak. Metropolitan, and Roger Cherugi, who is the new program director there. Sam. And Dan Egan, who I mentioned, is so this is probably the only other emergency department that has as many languages as Elmhurst does. And Allison Suarez is going to be speaking for them. And this is Jody. And Anthony, I'm going to pronounce this wrong. All right, so we're going to start. The first speaker is going to be Anand Swaminathan, and we're going to hopefully have a few minutes at the end for questions, okay?
All right, good morning, everybody. It's really a pleasure to be here. And again, I want to thank Dr. Shah and Dr. Jagoda for welcoming us in and all of the residents of Mount Sinai. It's really a pleasure for our residency to be here and also for myself to speak to you guys. And hopefully I'll impart a little bit of wisdom and hopefully some of you guys can take home with you. So the topic for the next 20 minutes is going to be aortic dissection. And I tried to come up with sort of a witty title, and I couldn't really because it all relied on videos that were inappropriate for the venue, but really a diagnostician's nightmare. I don't want to scare you guys, but when I think about this diagnosis, when I've had it in the past and I've really had a high suspicion, it's sort of gotten me to the point where I had to change my shorts, and it's the kind of way that you should think of it too, that this is pretty scary, but hopefully we can sort of figure out some ways to get to that diagnosis and enlighten ourselves. Hopefully you guys can hear me. Are there any commentary in the back? Okay, good. All right, so as always, we should start off with some disclosures. I have no disclosures, I take no free lunch, and so I sort of feel like this guy at the end of the day. I'm not even sure if Bellevue's paying me a regular salary, much less do I get anything from the drug companies. And these are the iron gates out front of Bellevue Hospital, which are very iconic for New York City and for emergency medicine in general. And while this is sort of what we have now in our past, I think we're moving towards the future of emergency medicine, which is going to look like this. And so, while I'm not currently taking any money, if Taco Bell were to offer me, I would happily take a little bit of money to put this sign out front of Bellevue Hospital. All right, so since I get to lead off, I get to impart a little bit of words of wisdom from someone smarter than me. Disease is old, and nothing about it has changed. It is we who change as we learn to recognize what is formerly imperceptible. And this is Charcot that said this. And I think this is going to translate well across all of the lectures. This is really what we're talking about. How do we get better at picking up the disease that was always there? All right, a little bit of background about the disease of aortic dissection. It was first identified or described in 1761 by Giovanni Morgani. And one of the great excerpts, he describes a patient who has aortic dissection, and they basically counseled him to accept God and move on because he was going to die. And I think that we've moved beyond that, but it sort of speaks to the fact that, even 100 years ago, the mortality for this disease was 100%. We're a little bit better than that now, and I think that's a good thing. It's hypothesized that King George II probably died of aortic dissection as well. And the description for this one, again, these old descriptions from doctors back in these days were great. His chambermaid actually heard him in the bathroom as he had a noise that was louder than the royal wind. as he collapsed off of his toilet, clutched by aortic dissection. And then lastly, someone a little bit more recent. This is Dr. Michael DeBakey, who's the most published person on aortic dissection and also was the first successful surgery in 1955. Many of you guys know the history of Michael DeBakey. I won't really get into it, but he actually got an aortic dissection at 97 years of age, which was repaired, and he lived for another about 3 years or so afterwards. And the really amazing thing about it is at 97, he was sitting in his chair at work and said, "Huh, I'm having a dissection. How about that?" Went home, went to sleep, figured he'd wake up the next morning. He wouldn't wake up the next morning. Woke up the next morning and said, "Oh, all right, I'm still alive. I guess I'll go to work." Went to work with his dissection, waited the whole day, and then in the evening he said, "I'm still alive. That's weird. I should probably tell somebody." And then it took him another 2 daars for them to convince him to get the surgery done. So, these are sort of the giants in medicine, not emergency medicine, but pretty cool story, I think. All right, now as we go through sort of how we're going to go through dissection, I want you guys to keep a couple of cases in the back of your head. These are all cases I've seen in the last couple of years where we considered dissection as for the diagnosis. So an 83-year-old man with hypertension and mid-sternal chest pain and headache for 24 hours. He was actually very comfortable. He had sort of the arms over the head, legs crossed, nothing could actually be wrong with the patient. But he had a note from his doctor saying, "Please admit me for ACS." Case number 2 is a 64-year-old man who has every cardiac risk factor you could possibly think of, as well as a PE. And he came in with symptoms that felt exactly like the PE that he had 5 years ago. Case number 3, this is a man with mid-sternal chest pain going to the arm, but he also had some transient leg weakness a couple hours before presentation. When we did his EKG, this is not an EKG lecture, but he's basically got ST elevations inferiorly with reciprocal changes. And so the STEMI team was alerted very rapidly for this patient. And then lastly, an 88-year-old man who had weakness in his left arm, and that was his presenting complaint. He actually came in as a stroke alert to one of our hospitals. When he was there, he looked like he was in quite a bit of pain, and someone finally asked him, "Sir, strokes aren't really that painful usually. Where's all this pain coming from?" He goes, "Well, I have chest pain going into my back and my arm." All right, so what are the goals of the lecture? We're going to spend about 2 minutes talking about a little bit of background in aortic dissection, and then we're going to go into constructing an algorithm for the diagnosis. So why do I care about aortic dissection? Well, the way I look at it is it's a perfect storm disease. It's rare, it's difficult, it's full of atypical presentations, and there's a great website, www.aorticdissection.com. And if you go there, you can actually see it's patient reports of stories in aortic dissection that are either missed or were caught and sort of how they presented. And it speaks to the atypical nature of the disease. It's well publicized and litigated. So most of us are probably familiar with the John Ritter case from not that long ago. I'm going to guess that most people in this room have never seen Three's Company, but it is quite possibly the greatest show on TV. But more importantly, this is happening, and you need to know about the fact that lawyers are also aware to this disease. Early recognition and treatment is vital. We're going to come back to that in a moment. And finally, it falls outside of our comfort zone. We like pattern recognition. We like to come to early closure, and it's actually one of the big problems in dissection is coming to too early a closure, not considering the diagnosis. So when we look at mortality, it sort of ranges based on where the dissection is, but somewhere between 20 and 35% is the overall mortality. So think about how many diseases we see in the ER that have mortalities of 1 to 2% that we're really concerned about. This one's 20 to 30%. And the last point is really the most important. The mortality increases by 1 to 2% for every hour the diagnosis goes unmade. All right, so there are 2 rules of aortic dissection. These are not my rules. I stole them from someone way smarter than me, and it really applies to any difficult diagnosis or any life-threatening illness. The first rule is that you can't diagnose every aortic dissection. No matter how good you are, you're not going to be able to. And the second rule is that if you're not okay with rule number 1, you should stop practicing emergency medicine. This is our life. We are going to miss critical diagnoses. The fact is that we can improve it, but we can't improve it to 0%, and we know that. The other problem is there is no holy grail. There is no holy grail for non-invasive diagnostic tests for aortic dissection. And so we're going to have to talk about how to get there without the holy grail. So how do we diagnose an aortic dissection? We're sort of starting backwards on this topic. CAT scan. And this is an image that shows a dissection in the proximal aorta. You see a lumen and a false lumen here. And of course, we also have TEE. So this is another modality less used because it's less available, but also definitely an option. The problem is, though, we can't CT every person who comes in the building. Sometimes we feel like we CT everyone that comes in the building, but we can't do it. How many patients did you see with chest pain yesterday during your shift? We can't CT all of them. So the real question is, who do I pursue advanced imaging? So the first and most important thing is the disease has to be on your radar. If you're not considering it, you're not going to find it. It's pretty simple, but it's really a big tenet in emergency medicine we have to stick with. And then how do we go through figuring out who to pursue imaging of? So the first thing is we have to start with a history. And I know you guys are probably tired of hearing attendings say, everything's in the history. You got to do a good history. But this is a disease where you really do need to get an extensive history in order to be alerted to the diagnosis. Then we're going to factor in risk factors. And those two things together happen pretty quickly, and they give you this blink moment for those of you guys who have read Malcolm Gladwell. It's sort of that very quick assessment of a patient. And that's going to help us to decide whether we need to go down the dissection pathway or not go down the dissection pathway. Now, of course, this blink moment is sort of a double-edged sword, because I just told you guys we don't want to have early closure. But you really do need to identify these patients that you're worried about early on. We're going to add in pertinent physical findings, and we're going to look at basic chest pain diagnostic tests, which we're going to get on a lot of these patients anyway. And then finally, we're going to consider who we need additional testing on, and that's really advanced imaging. All right, so let's start with the history. What are we looking for here? So the classic aortic dissection history, these are the things that we look at, right? Chest pain, tearing, radiating to the back, sudden and severe at onset. And of course, we all know that if something is described as classic in medical school, it's less than 20% of the time. So let's see how that really pans out. So the International Registry of Aortic Dissections, this is a great paper where they looked at retrospectively at all of these dissections and what symptoms, signs, what EKG, what chest x-ray findings they had. Unfortunately, the table doesn't come across really well, but here you see the main points. 73% have chest pain. Well, that sucks. 27% of people with aortic dissection don't have chest pain. Tearing quality of pain, 50%. Radiation, only 28%. Back pain, 53%. And some of these patients who didn't have chest pain, a lot of them had back pain only, which is more common in a type D dissection. Sudden onset and severe onset were actually pretty good. And so this actually makes me think of subarachnoid hemorrhage. The sudden and severe onset pain always worries us. So sudden and severe chest pain, sudden and severe back pain, abdominal pain, dissection's got to be on your radar. And here's the really disturbing number. Painless dissection, 4.5%. This is sort of where emergency physicians throw up their hands and walk out and say, I'm not coming back for a week. I got a painless dissection. This sucks. But these are the cases that unfortunately sometimes we are going to miss. What else did we find from this IRAD study? 9.4% had syncope. And of those syncope, 2.2 were painless syncope. So again, anytime a person has syncope, this has to be in your differential. I'm not saying that you got to pursue dissection in every syncope patient, but you got to think about it, at least for a couple of seconds. People with type A were more likely to have chest and anterior chest pain, and people with type B were more likely to have back and abdominal pain. So hopefully this helps a little bit in sort of teasing out the diagnosis. Now, this is a study where they looked at about 83 patients, and they identified 3 things that they thought were important: location, quality, and onset of pain. And this was, again, a retrospective review. And what they found was that 19, or about 25% of the patients in the study didn't have any of these documented on their chart. They assumed that meant that the doctor didn't ask those questions. Now, I think that's a tough assumption to make. Sometimes we don't document what we ask. But when they were all documented, 33 patients had all 3 of those documented. 30 of them were diagnosed with aortic dissection before the imaging modality was obtained. So the doctors got a higher likelihood of having a dissection for the patient when they ask those questions. So again, we all know what the problems are with retrospective studies, but this sort of speaks to the fact that we have to ask a good history in order to get to the diagnosis. So what are the key points for the history? Well, again, abrupt onset, and it's usually severe at onset. And these should sort of tip you off that something's going on more than simply ACS, which usually builds up over a couple of days. Syncope can occur in up to 10% of patients, so consider it when you have a patient who syncopates. And these two, not really from the IRAD study, but other things that we sort of look at. Symptoms above and below the diaphragm. There aren't too many organs that are above and below the diaphragm. The aorta is the one that links everything. So when I have a patient who has chest pain and belly pain, you got to think about dissection. Chest pain and leg weakness, you got to think about dissection. Headache and chest pain, not really above and below the diaphragm, but the same kind of thing. It's the chest pain plus syndrome. So you have chest pain plus something else. There was a case I read about in a patient who had chest pain and had hoarse voice, which happened to be from a recurrent laryngeal nerve palsy from his aortic dissection. Now, that's a tough one to pick up, obviously. Some very astute physician picked it up 3 days after the patient was admitted for ACS, and those are hard. But this is sort of the things that we have to be looking at. When the patient gives you something aside from the chest pain, don't just focus in on ACS. Think about, well, how could that be linked to their chest pain? All right, risk factor assessment, we're going to spend a very brief amount of time on. We sort of all know hypertension is the one we all talk about. And this is really chronic hypertension. It's not hypertension on presentation. They have a history of chronic hypertension. Previous cardiac surgery, specifically aortic valve repair. History of TB or syphilis. Connective tissue disorders, we're thinking about things like Marfan's or Ehlers-Danlos syndrome. Family history of aortic dissection. Cocaine use is a big one. Again, cocaine use and hypertension are sort of the same in RED. We just assume that patients have them because they're so common. So obviously not every patient who uses cocaine has a dissection, but it's definitely a higher likelihood in cocaine with chest pain. And then some other ones that are coming out more often. Pregnancy is coming up more and more in the literature as a possible risk factor for aortic dissection. And polycystic kidney disease has become much more established. So other things to look for when you think about chest pain and pregnancy, we always go to PE, but maybe we should be thinking about this diagnosis as well. All right, physical exam findings. So again, when we go back to the IRAD study, they looked at sort of the classic exam findings. This is what they found. When the patient presented to the hospital, hypertension was found in 49% of patients. More so in actually type B dissections. The AI murmur, 30%, pulse deficit 15%, and CVA about 5%. The things that were kind of interesting to me was that SBP under 100 was found at 8%, and SBP less than 80 was found at 8.4%. So 16% of patients were hypotensive when they came to the ER with the aortic dissection. And these patients were found to have a much higher risk for tamponade. So they had type A's that were going back and providing a tamponade on the heart. This is something that we can diagnose pretty easily, and we have therapies to save these people's lives. So when the patient comes in hypotensive, it should really set you off to thinking about, well, they could still have a dissection, but maybe I should slap that ultrasound probe on and see if they have a pericardial effusion. So what were the real key points from the physical exam findings? Well, the first one is that the vast majority of these patients don't have any of the classic physical exam findings that we're all taught about. But if they do have one of those findings, it really has to set us off down that pathway. So if you have a patient who comes in with sort of a story for aortic dissection, but they have a pulse deficit, you better be getting that CT pretty quickly. So when you have hard findings in a patient without a great story for aortic dissection, it really turns up your radar and really makes you look for this disease. And again, an SBP under 100, you got to really think about tamponade or at least pericardial effusion for those patients. All right, so now how about basic testing? So we move past the physical exam, and they have chest pain, maybe they're older, maybe not, and you're going to pursue your usual cardiac workup. So the first thing to kind of get out of the way is labs. Labs are useless here. There's not a single lab that's really going to tip us off, and I'm going to come back to that in a moment, because there's maybe one we should consider. Chest x-ray we're always taught we have to get, and that's going to help us. And an EKG we're classically taught is pretty useless, actually, in this diagnosis. Let's see how that all pans out. Well, chest x-ray, here are the classic findings. Widened mediastinum, abnormal aortic contour, and a displacement or a calcification of the aorta. And we look at a couple of examples of chest x-ray. This is a widened mediastinum. I challenge anyone to miss the diagnosis of aortic dissection on this patient. Here's another one where you see the mediastinum is widened and the aorta is displaced. And then here's the calcium sign, which we don't see as much. I think is pretty important. It's a displacement. It says double calcification. You can see. Oh, wow, that's not the right one. There we go. This double calcification line you can see on the aorta. They usually talk about a ½ a centimeter between the two lines. And it's very specific, very sensitive for an aortic dissection. But how common are these findings? So again, we go back to the IRAD study, and what they said is about 62% of patients have a widened mediastinum. 50% have an abnormal aortic contour, and that calcium sign is pretty rare, about 14%. So none of these are really approaching the diagnostic accuracy we'd like. 12%, no abnormalities, and this is a retrospective look where they knew they had dissection. 87 to 88% had something. So what do we do with this? Well, there's a couple of things we have to take away from this. First is that chest x-ray is not a holy grail for this. This does not give us the diagnosis. However, there's some abnormality 88% of the time. So if we tip in or we clue in our radiologist and say, hey, I got this guy over here. I'm a little worried about aortic dissection. Can you take another look at that chest x-ray and see if you find any of these more subtle findings? That may actually help the diagnostic accuracy of the radiologist. The other thing I take away from this is, again, let's say we have a patient who comes in saying they have chest pain, it's going to the arm, it hurts worse when they walk, and you're like, all right, that's easy. This is ACS. I'm going to admit him for ACS. No problem. You get a chest x-ray and you find one of these things. You find an aortic calcification sign or a wide mediastinum, you got to go after it. So no matter how benign the patient's history sounded from a dissection standpoint, if you find one of these very high-risk diagnoses on the chest x-ray or high-risk findings, you got to pursue the diagnosis with a CAT scan. Okay, going back again to IRAD, and they talked about EKG findings. Again, we're sort of classically taught EKG doesn't show us very much. What did they find? Only 30% of EKGs had no abnormalities. So that's kind of disturbing as well. The abnormalities they found on most of these were non-specific ST and T wave changes, so not that helpful. 15% had clear ischemic changes, and 3% had acute myocardial infarction. So another scary one. So if you're working in some tertiary hospital, if you're working in a community hospital, and you have a patient who comes in with an acute MI, and you can't transfer them fast enough, you're considering thrombolytics, and you got a kind of a clean kill on your hand. You got a guy with a STEMI, you give him thrombolytics, he actually had a dissection. So we don't want to do that. So how are we going to tease these out? Well, if you pursue dissection on every single patient who comes in with an MI, you're going to do more harm than good. Only somewhere between 1 and 3% of dissections have STEMI pattern. To phrase that differently, about 1 to 3% of patients with STEMI will have a dissection. And so who should we consider dissection in acute MI? One of the things we look for is an inferior distribution. So when you get an ascending dissection, it preferably goes into the right coronary artery, which is usually going to show you an inferior wall MI. So when they have an inferior wall MI, you should get a little more tuned to it. The other thing that you don't want to do is, and we all probably do it at some point because we're all STEMI centers. This person comes in as a STEMI node, you look at the EKG, you're like, yep, that's a STEMI. You hand it to the cardiologist and you let them do whatever they want. But you got to ask the guy, did you have back pain with this? Did you have radiation? Did you have any leg weakness? Did you have any arm numbness? Because these things are going to sort of tip you off. And when you have one of these sort of high-risk presentations, you got to go after the dissection. Sometimes even when the cardiologist doesn't want to pursue that diagnosis. The risk, of course, is that you load them up with a bunch of things like Plavix, heparin, bivalirudin, et cetera, and now you got a highly anticoagulated patient with a dissection. And so that's really where the money is. It's with these people with inferior STEMI who have a concerning story for dissection. We have to go after it. All right, so going back to basic testing, the key points, labs are pretty much useless. Chest x-ray is normal in about 12%, so you can't rely on it, but it still does have some utility. And EKG is only normal in about 31% of patients. So you should expect to see non-specific ST or T wave changes and possibly MI. Now when we go back to that one lab test that may be useful, the D-dimer is sort of coming up more and more in papers as a possible diagnostic test. This is just one paper where they found a sensitivity of 99%, and they concluded that a D-dimer alone may be enough to rule out the diagnosis of aortic dissection. And there's a pretty famous cardiovascular surgeon out of Yale, Dr. John Leftriades, who's the only person aside from he's the most published person outside of Dr. Hideki on the topic. And he says D-dimer alone is enough to rule out this diagnosis. Well, the Annals of Emergency Medicine published another paper, which is sort of a review, and what they found was that the sensitivity for this test can go anywhere from 80 to 100%. So I don't think it's really good enough for prime time if we're talking about 80%. So what's the bottom line on this? The benefit is that it's non-invasive and it has no radiation, but the studies had variable sensitivities. They weren't positive in patients with intramural hematoma. This is basically a dissection where there's no intimal tear. So there's not blood or products like D-dimer leaking out into the circulation. These are the ones that are pretty high risk for not being picked up, and they need to be treated exactly like an aortic dissection. And I don't know how about your hospital, but in my hospital, D-dimer takes about 90 minutes to 2 hours. So if you have a patient who actually suspects the diagnosis, I don't want to wait 2 hours to get that D-dimer back and then pursue a CT. So there can be some delays in diagnostic testing. So when we come to the conclusion of all of this, what it really tells us, again, is that history is the key. We've got to be looking for those chest pain plus, the little thing that sticks out that doesn't really sound like ACS. And now this is a really advanced slide. It shows you how good I am with PowerPoint and computers. Which sums up, yes, I grew up in the computer age. I'm not as young as I look. It's a little sad, this is what it came to, but this sort of boils down the way that I think about dissection. So if they have symptoms, so first we're starting with the disease on our radar, then we're looking at their symptoms. If their symptoms are concerning for dissection, do not pass go or go right to CT scan. There should be no testing, there should be nothing done except that CT scan. If their symptoms are completely non-concerning, you have to stop. Now I'm saying you have to stop, but you should stop at that point. Now a lot of these things we're going to do for our ACS too, so we move on to risk factor assessment. If they have risk factors concerning, like oh yeah, my mom, my dad, and my two brothers all had dissections, and by the way, I have Marfan's and I use cocaine and I'm pregnant. We should probably pursue the diagnosis by getting a CT or a TEE. Okay, the other risk factor that I thought about this morning, John Ritter had a dissection, and so did John Larson, who was the guy who wrote Rent. So if you're in media or if you're in performance and your name is John, you probably have a dissection. Physical exam findings. So we move on and we say, well, I didn't really think this guy had a dissection, but he's got a pulse deficit. They get a CT or a TEE. And then you move on from there and say, well, I didn't think this person had a dissection. Their exam was normal. They didn't have any risk factors. But their chest x-ray shows a mediastinum the size of their entire chest wall. They should probably get a CT or a TEE. And then at that point, when all of that is negative, that's when you have to consider, am I going to drop the diagnosis? Am I going to move on and say, I don't think this is a dissection? And this is sort of what a reasonable plan. Now, some people would insert D-dimer here and say, well, all of this stuff is negative. None of this stuff is really telling me it's a dissection. I'm going to get a D-dimer to really close the door. And this is sort of adding on each other and saying, well, all of it's negative, chest x-ray is negative, D-dimer is negative, maybe I should drop the diagnosis. But what I always tell my residents, if there's something nagging you in the back of your head after all of this and you're like, I don't know, there's still something odd about this guy, there's something wrong about this story, I would just go ahead and get it. You're going to get way more CTs to rule out dissection than people who actually have it. So if every time you pursue the diagnosis of dissection, the patient has a dissection, it means you missed a ton of them. We know this. This is how we are on everything, right? So quickly, let's go back to those cases. So case number one, the guy who was sitting with his hands behind his head, legs crossed with a note saying, admit me for ACS, who thinks he has a dissection? Of course he has a dissection. It's a dissection talk. This guy had an ascending dissection going through his bilateral iliacs. He'd already clipped his left renal artery. Okay? CV came down, they looked at us and said, why did you think to diagnose this guy with a dissection? And of course, we said, we're really good. But the truth was, I just didn't like his story that he had constant chest pain for 24 hours. And so what did I get a CT for? I got a CT to rule out a PE, thinking that maybe this guy has a PE. And on the PE study, they picked up a dissection. How about this guy? The guy who says, I had a PE and I'm having a PE again. How many people think he has a dissection? So this guy swore up and down it was a PE, and so he came in, it was busy, and 20 minutes after he hit the door, he got heparinized. And 3 hours after he got heparinized, he got a confirmatory CT scan which showed a dissection. He actually did quite well. He was actually a man of God. Literally, he was a priest. So we were all like, oh my God, if this guy dies, we're all going to hell. And he actually did quite well. I saw him about a year ago. He came in for something completely unrelated. All right, how about this one? This is the guy who's got a STEMI on his EKG, but he had transient weakness in his left leg. Who thinks he has an aortic dissection? So this one, the STEMI team came down. They started, pushing their Plavix and their aspirin and their heparin, and they're running them up to the lab. And I'm like, we're going to chest x-ray before we go to the lab. And they're like, what do you mean we're going to chest x-ray? I'm like, he's got left leg weakness, I'm worried about a dissection. So we got a chest x-ray which showed a mediastinum like this big. And he got a confirmatory CT which showed a dissection. CV came down and took this guy to the OR. So within about an hour of him hitting the door, he was in the operating suite. And unfortunately, he died on the table. He had a very bad proximal dissection that killed him. That's his EKG one more time. And the last one, 88-year-old man who comes in as a stroke alert, who also tells us he's got chest pain going to his back. Who thinks he's got a dissection? It's a loaded question now, right? So he has a dissection too. So he's got true neurologic findings with this. Now the problem here, of course, was that nobody got that chest pain story for a little while. And so neuro wanted to give him TPA. And so this is another one of those clean kills, right? So he's under the window. He's in the window for TPA getting pushed. And finally, somebody asked the guy, because we all walked away from the bedside once the stroke team came down. But finally, someone asked him, sir, you seem to be in a lot of pain. Where's the pain coming from? Oh, it's from my chest. It's going to my back. And that's when he got the diagnosis. He went to CT scan to confirm it. He had a type B. He went to the OR. He actually did pretty well. He went to the OR because he had actually clipped off other vessels. All right, so this is one last quote to leave you guys with. Difficulty in diagnosis. Delay in diagnosis or failure to diagnosis is so common as to approach the norm for this disease, even in the best hands instead of the exception. This again was Dr. John Leftriati's that he wrote in his textbook on aortic dissection. And I bring this up for two reasons. One is that if the guy who's the most published living man on this disease can't always pick it up, you should be a little reassured that, yes, I'm going to miss this, but I have to do as good a job as I possibly can. The other thing is when I get called for my lawsuit on aortic dissection, I'm calling Dr. John Leftriati as a witness. All right, so that's the end of my talk. I do think knowing is half the battle, and hopefully I've given you guys some tools to help you diagnose this disease. These are just a couple of papers to prove that I know how to read, and I'll take any questions in the last couple minutes before we move on.
Any questions? Anand went through 68 slides, and I was giving him a hard time. He's not going to make the 25 minutes, but he did. Go ahead.
With your use of D-dimer, are you talking about the higher sensitivity D-dimer or the platelet?
It's got to be the high sensitivity D-dimer. You have to have a good one, and what they're talking about is a cutoff under 200. Right, so we all know that D-dimer doesn't decrease our risk of scanning for PE. It increases the rate of scanning, and this is sort of the same thing. It's a very non-specific test, but it is something there. If you really have a low suspicion to use it to rule it out completely, it's not an unreasonable thing.
After all your risk factors that you go through in your chest X-ray and your EKG, and you think about getting a D-dimer, but it comes back greater than 400, what would you do then?
I think you have to pursue the diagnosis at this point. You know, it's sort of how many times do you have someone who comes in, young woman with chest pain, you're like, I think it's musculoskeletal, let's get a D-dimer and rule out a PE. And then it comes back positive. What do you do with those patients? You sort of are you're in a bind. And you kind of are thinking to yourself, I should have never gotten that D-dimer in the first place, right? That's what we all think on a regular basis. But once you get it and it comes back, especially if you've been charting the whole time and saying, I don't think this is an aortic dissection, then you got a positive D-dimer, then you have to go ahead and scan that guy. Or if they're really stable, you can go ahead and pursue a TEE, so you don't have to radiate this person. If you have, I mean, you're from downstate, so you probably have access to TEE almost as much as I do, which is like this, right? But every once in a while, you can get some interested cardiologist who like hasn't done a lot of them to come down and do one. But you know, that might be a patient that you get a TEE on, non-explosive to radiation. But once you've got the positive test, I think you're sort of bound to pursue it because you had a suspicion for a reason. You got the test for a reason. This is why shotgunning the labs is also a bad idea, right? Yeah.
If you've got the STEMI patient who then has liability time and the cardiologist is already there, might it be faster or better just have them take it to the lab and do an echo?
Yeah, so that's a really good point. So why not just take them to the lab, when they shoot the LV gram, they'll actually see a dissection if it's there. And I don't think that that's a bad idea. The only problem, and you know, cardiologists in my shop might be different than yours, is they want to load them up on every single antiplatelet, anti-everything that they can find before they get them to the lab. So if it's going to be that situation where they're like, we're going to give him everything before he gets there, then I have to say no. It's still my patient. I'm still taking responsibility. I'm taking him to the scanner first. You know, I've only done this one time when it was so clear that the guy didn't have ACS to me, and so clear to the cardiologist that he did. Because he did. I mean, he did have a STEMI. He just happened to also have a dissection. So, yeah, I mean, it's not unreasonable if you can work that out with your cardiologist. All right, thanks a lot, guys.